Good morning, everyone. Welcome to day 2. Today, we are going to the first session for today is the Palliative Care Special Interest Group session. But first, and most important, it's my honor to thank our sponsors, without whom no IoT conference is possible, whether virtual or otherwise. I'd like to thank our diamond sponsor, National Cancer Institute, our silver sponsors, Electa, Novartis, Takeda, and Variant Medical Systems, and our bronze sponsors, American Cancer Society, Beckman Coulter, Bristol Myers Squibb Foundation, CAFAID, and IGCS. My name is Dr. Rekia Saidu, and welcome to this morning.
And hello, my name is Nomonde Mbatani. I would like to welcome everyone. And I would also like to strongly urge everyone to use the virtual platform that we have, where one can post the questions and answers. And in addition to that, there is the wall for who the sponsors are, as Dr. Rakia has mentioned, and exhibitors who they are. And please, I would encourage people to play on the treasure hunt as well. So this first session, 2 people are presenting, and that is Dr. Emmanuel Luirica and Dr. Christian Zimira. Apologies for that. And they will be the 2 facilitators for this session. Thank you and welcome.
It's a really pleasure to welcome you to this palliative care session. The program Executive Director of APCA, African Palliative Care Association, Dr. Emmanuel Luirica, will be presenting in 15-20 minutes about the aftermath of COVID pandemic on palliative care in Africa, what the lesson learned and also the opportunities. We will have a Q&A session with Dr. Luirica, of course, from this East Africa, and also board member of the USCC, Dr. Miriam Mutebi, who will moderate a panel discussion oncology, so experiences about delivering palliative care services in COVID era. What are the innovation? And also we will be concluding also palliative care in universal health coverage. What has the government done? And we will have, please, as suggested, please use the platform. If you any questions, and please send it to us, and the speakers will be able to answer that. So without taking much time, as they said, my name is Christian Izimira. I'm a palliative care physician, but also executive director of the African Center for Research on End-of-Life Care, which is really based in Kigali and Rwanda. I'll be moderating with my colleague, Dr. Emmanuel Luirica, the executive director of APCA. So without taking much time, I would like to invite Dr. Emmanuel Luirica for his presentation. Thank you.
Thank you very much, Dr. Christian, and thank you very much, the Aortic hosts, for organizing this event and allowing palliative care to have a session at this meeting. As I was thinking about this presentation, I wanted us to have a very interactive session that looks at the things that we've all gone through at a professional level and at a personal level. We've had COVID since last year. We've had lockdowns in most of the countries, apart maybe from Tanzania. And so we've had the effects of the disease itself at individual level, at family level, at professional level. And then we've had the effects of the lockdowns and restrictions on movements and what that has had on our personal lives and the lives of individuals who are already in palliative care programs. And then the flow of patients into palliative care programs as a result of the COVID-19. And then definitely one of the huge things that has happened is the issue of isolation of individuals without before the discipline developed protocols and guidelines on how to manage patients who are isolated with infectious disease or out of fear of acquiring infectious disease. So my discussion is going to focus on three things. One, what has the COVID pandemic exposed? Two, what lessons have we learned? And three, what are the opportunities? And I intentionally didn't prepare slides. I wanted us to focus on these things because they have happened right before our eyes. And those of us who have not been exposed, we may be lucky, but we know many families that have suffered because of the pandemic. At a personal level, I've had some family members affected. I had a sister spend a month in ICU. I lost a brother-in-law in January. And then I lost 6 cousins of my father. They all died in 2 weeks and they were all buried in the same place. And so each one has a story. Each one has a story to tell about COVID. And therefore, as we study the effect of COVID and of COVID-19 and the lessons and opportunities for Africa, we are literally planning for ourselves. There is a personal interest, a professional interest, and a public interest. So I want to draw our attention to the fact that when COVID-19 appeared, one of the first things that came first was misinformation. There was a lot of misinformation. Initially, people in Africa felt, oh, we will not have it. It's a European problem. It's a Chinese problem. And then when it came to Africa, people said, oh, it's a South African problem. And eventually, even all those countries that kept saying it's a problem far away, they realized it was their problem. And up to now, we still have some communities in Africa who think COVID is not a major issue because they have not seen somebody who has been diagnosed as COVID-19 and died, even when people have died in their communities. So we've had the tyranny of misinformation. Moreover, without pre-prepared systems to handle misinformation in the health sector, you find a country like Uganda, which has 54 dialects, and all the official communication is in English. Much of the translations are really local efforts by communities and not as a system. And I think that's where we may need to learn from South Africa on the way they manage all their 9 major languages. So, and that happened in many other countries. So misinformation was one thing. And then number 2, as I've said, the lack of proper channels to fight the misinformation as it came. And so that is something that is big. You have misinformation, and at the same time, you don't have inbuilt systems for fighting misinformation. The third thing that comes to mind is the whole issue of critical care. One, we had critical care and ICU systems. In most of the African countries, we had very few ICU beds. That's one. We had very few professionals, and we had not integrated palliative care within those critical care systems or intensive care systems. And if you take an example, Uganda, at the time of the declaring of the pandemic, there were only 55 ICU beds for a population of over 42 million people. And these were literally in the city, only in the capital city, and none elsewhere. And so that was another major issue. Palliative care providers and advocates inclusive had made efforts to advocate for integration of palliative care into other systems, but that had not completely happened. So that's where we found ourselves. The other thing that came up is that the palliative care providers had not been fully oriented in the management of highly infectious diseases. we used to think, oh, that would be Ebola, and there is an Ebola team to manage that. Oh, that is another hemorrhagic fever, and there's a team that manages that. And so it was very unlikely that you had a hospice or a palliative care team that had all the skills to operate within the context of highly infectious disease. The other challenge which COVID-19 unearthed is that as palliative care providers, we are used to going to patients' homes or patients coming to our hospices, or in some cases, people who ran community outposts where some patients would be brought and they see them and they go away. Now, we had a situation where you had a lockdown and there was no way you could access patients or patients access you. It also came at a time when hospices and palliative care departments did not have enough funds to buy personal protective equipment. All the money they had, the little they had, was for specific things that they needed to deliver the services. Then we had issues around fighting we had people who were fighting responses to COVID-19. You had some churches that were saying, oh, this is the end coming, others assuming that this is any efforts for vaccination coming from the Antichrist and all that. So all those are issues that we were never prepared for. So what are the lessons? What are the lessons that we've picked from this? One is that integration of palliative care into all care systems is inadequate. We can all attest to that. It largely on the continent, it's inadequate, and we need to move. Whether those systems are delivering care at home, in the community, at the hospital, at the hospice, or any other facility, we've not had adequate integration. And that has meant that many patients suffered in isolation with symptoms that could be managed, and whether in their homes or in hospitals. So that's one big lesson that we've learned. The second one that we've learned is that we have to empower the palliative care providers with skills and equipment to operate within an environment of highly infectious disease. That is another big lesson that we've learned. Thirdly, we've also learned that for us to operate in such an environment, we need to invest in telemedicine and platforms that allow us to deliver services without necessarily being physically present, and also investing in systems that deliver patient consumables to their homes when the services, when the need arises and we are unable to reach the patient, as happened when the lockdowns came up. The fourth lesson that has come out of there is devising mechanisms of dealing with isolation and spiritual issues in the case of a lockdown for our patients who are in programs, but also for patients who have palliative care needs and they have COVID-19. That's another major lesson for us. Finally, on the issue of lessons, is the issue of preparing communication packages in the languages that patients and their families and the general public understand. Many countries were caught unawares, and therefore, that's a huge lesson for us, that we should not take the communication aspect for granted when we are thinking of palliative care, when we are thinking of any other intervention, to have properly packaged messaging that can be delivered to the general population. So that's in terms of lessons, that's where I want to stop for now, and I'll give room for people to add to that. Now, so what are the opportunities? What are the opportunities that we have? One is to leverage the COVID-19 resources for palliative care. That is something that we must push for wherever we are. And secondly, to adopt new platforms for service delivery and for palliative care education, telehealth, telemedicine, and even having our conference like this is one of those things that is beneficial. And then looking for ways of moving money that we've been using for other things, travel and all that, into palliative care and other service delivery, and also to integrate infectious diseases training into our modules for palliative care so that we prepare teams that can handle these situations when they arise. Thank you very much.
Thank you, Dr. Emmanuel. Thank you for the great presentation and for the experiences. And as you said, many people lost family members, friends during this COVID pandemic situation. I would like just to mention to the stream, that the studio, that we have echo here. Is it possible to?
Christian, I can hear you very clearly. Your voice is very clear without any interference. Maybe, yeah, I can hear you very well.
Okay, so let's go. I hear some echoes, but it's fine. So, Dr. Emmanuel, thank you for the presentation and about the situation in Africa. We don't have any question now, but I have mine based on your presentation. As you said, many African countries really faced during the COVID-19, especially access to vaccine. And also we heard also, as correct me if I'm wrong, about some stigma because patient was really waiting for palliative care people to visit them. And we know that the power of the presence of healthcare givers during the visit of patients in palliative care. So my question is, what do you think in most in African, based on your long experiences managing palliative care in many different African countries, what will be the best approach African countries, or especially from the government, to making sure that, because according to what people say, that could not be the first or the last pandemic, maybe we expect more pandemics. And I'm sure that that will affect also palliative care as well. So what is the best approach you think African countries, except for all the lesson learned you described, to make sure that no one will be left behind again? Because even if the rest of the public health system are being affected, but palliative care patients, the most vulnerable population, are really, really affected. So what is your best approach based from?
Okay, thank you very much, Dr. Christian. When the pandemic started last year, the African Palliative Care Association, working with King's College London, did a quick survey in a number of countries. And we're asking palliative care providers, what are the challenges they faced? How are they able to overcome those challenges? And from that study, we realized that palliative care providers did not have access to enough resources. And because they did not have access to enough resources, they could not reorient themselves and be able to buy personal protection equipment. And health workers who are running palliative care programs could not face the pandemic without assuring their own safety. And that was a major issue, lack of access to adequate resources for the palliative care providers. And that calls for more investment into the healthcare system in general, but also in palliative care in particular, because the UHC, as our colleagues talk about UHC, and from the continuum from promotion to diagnosis to treatment to rehabilitation, survivorship, and palliative care, we need to push for governments to invest in programs that cover all those aspects. Without providers being equipped with the skills and the protection, it will be difficult for them to deliver the services. So I think there is an issue of investment, and I believe that will be discussed in a bigger manner when they talk about UHC. But for us, in that study that we did, it was a major issue, having inadequate resources. We had to work with the donors to ensure that they allow or the providers who had money through us, they could reorient and use the money that we had already allocated them to meet these emerging needs that they have. And this should have been the responsibility of governments where these programs were running. So, Christian, that was a big issue, and we need to push governments to help with that. With the exception of countries that already had near universal health coverage programs, but the rest really struggled with that.
Thank you, Manuel, for your response. I would also invite other speakers, and also if they have a question for Emmanuel. But I would like to, before to give them the floor for if there is any question. I have a, let's say, very fun question for you, Dr. Manuel. Let's say today you become the Minister of Health in Africa. You have been elected by African Union to be the minister, representing the minister of all the ministers of health. And I know you carry palliative care in your heart, and they give you all the budget you want. What will be the 3 priorities from the first actions from your cabinet and your office?
Christian, that's a very, it's a very hard and futuristic question, but I think I can have a go at it. If I became the Minister of the United States of Africa,
yes.
One of the things where I would invest my money first, one is the manpower.
Okay.
Because COVID has demonstrated to us that if you have your teams and they are equipped, both in skill and equipment, they can venture out. So one of the things I would do first is to have trained manpower and give them the equipment they need. Then number 2, I would invest into the service delivery itself in terms of the medicines, the appropriate technologies and equipment that the health workers will need, the facilities that they need to provide those services. So I would focus human resource, services, and then finally, I would look at innovation, because COVID has made us think beyond the box. And so we've seen lots of new innovations that have come up. And so after looking at human resource and the actual service delivery, I would invest in innovations that would help you save on the time that health workers spend delivering the services, but also save on the money that you spend to deliver those services. Thank you very much, Christian, for that question.
Thank you, Dr. Mele. I know it was a very provocative question, but thank you for the good answer. So we have a hand up, Anna Nyakabau. Please go ahead with your question. Thank you.
Thank you very much, Emmanuel. Thank you, Christian. My question is, as Africa, we've often had financial challenges, and you are talking about investing in human resources and so forth. Would this be feasible?
Thank you, Anna. Okay, Dr. Emmanuel.
Thank you very much, Anna, for that question. This is very feasible and it's very possible. We've just demonstrated to people where we can draw the money. Sometime last year, we were involved in an advocacy discussion here, focusing specifically on Uganda. And we looked at where the money goes. For example, we were able to find over $100 million that the government of Uganda spends on taking people abroad for treatment, and its officials abroad for treatment, over $140 million. Now, if you are investing into your health care system, that is money that can be brought back, and you invest into your system and you are able to deliver the service. Number 2 is taxes. There are some products that actually harm health in Africa, and we are taxing them jokingly. The soft drinks, the tobacco, the alcohol, and these are huge budgets. And that money could be used to invest in health, including healthcare, training healthcare providers. Number three, wastage. We have a lot of wastage in our systems. If you think of some countries where you have big cabinets, you have 84 ministers in a population of 40 people, and you have 84 ministers really, and each minister has a lead car, has an official car, has an escort car. Those are three. You can cut money and you say, oh, everybody should ride there, get their own ride, but we provide the services. So it's an issue of really priorities. If we force our leaders to prioritize health, and COVID has demonstrated that, because when we had COVID lockdowns, nobody could be flown out, not even the top executives of countries. So we have the money. The money is there. It's really moving it from one sector into another sector. Thank you very much, Anne.
Thank you, Emmanuel. We have also Rene. Rene, can you ask your question or if you comment? Or...
Thank you. I just want to concur what Emmanuel says about investing, and I agree with him that when we invest, we should invest in trained manpower. I think that we've demonstrated that in the Western Cape, where we had trained palliative care teams. They were able to continue the service and above all train other healthcare workers to provide the service and to actually provide the symptom control. Where there were no trained palliative care providers in systems, the patients did not receive any palliative care. And again, it's not just the COVID patients who required the palliative care, but it was also those known palliative care patients who really suffered because there were no palliative care trained resources available for those patients. So I can concur, if I had that $1 million, I would also put trained healthcare workers in place.
Thank you. Thank you.
Thank you, Rene. This is bringing me more question in my mind. Dr. Manuel, so what about, sorry, Zippy, go ahead before I can ask my...
Sorry, I'll not have my video on, so
it's okay, it's okay.
I'm having connectivity issues. I just wanted to add to, I think what Dr. Manuel has discussed is very important, but I think we could also look at a bigger picture because they're talking about a future that that's going to be able to sustain palliative care services. I think investing in training each and every healthcare provider who goes to, anybody who's going to train as a healthcare provider, from the time they're going into their training undergraduate level, to understand what palliative care is and what, how they can support patients wherever they are, is a very big investment, because then you do not have to worry about extra training later on, especially except for those who want to become specialists. But every nurse, every doctor, every pharmacist, every medical social worker, physical therapist, if they get the basic training on palliative care, they will be able to provide palliative care wherever they are. So you might not necessarily need to have a unit, a team, but that person who's providing those services should be the first contact person for the patient to provide services. Of course, having specialists and whatever is also very important because they're key. And unless we have specialists in palliative care, we'll never get palliative care to the level where we have ops, gynae, surgery and the rest. So we still need specialists. In terms of I think we have to invest in strong, resilient healthcare systems, and WHO has got those, building blocks that really help us understand how to do this. And I think we need to focus on this also in terms of palliative care. We've seen what COVID has shown all of us, that nobody was prepared, even the West was not prepared. And again, for us developing countries, this time we also started realizing the West is struggling with its own health issues. We need to look at how do we put our own money into our own health and stop, wanting grants from ODA, UKAID. They have reduced their funds drastically. This is going to affect all NCDs, and NCDs are part of what we do as palliative care providers. So I think we need to look at what can we do to build our own strong, resilient healthcare systems that can be sustainable, that can not collapse when there's an epidemic, that can try to, continue services. We saw a lot of challenges, but luckily most of us have actually worked out those challenges and have been able to overcome them. So actually, I think there's a lot to learn from this 1.5 years that we've gone through. We've learned a lot and we can still do it if we really focus ourselves. Thank you.
Thank you, Zippy. Thank you for your comment, as you said. Just to before to go to the next session, Dr. Emmanuel, just in one word, palliative care in post-COVID situation, one word.
It's investment.
Thank you. Thank you. Thank you so much, Dr. Emmanuel. I think we are together. We continue the session. I'm now going to give the mic to my colleague, our Vice President of West African Aortic, Dr. Miriam Mutebi, and also board member of the board of the USCC, to go to the next session about different panelists we have. But before to start, one of our colleagues, Nala Gaffer from Sudan, just wrote to us she couldn't attend because of the political situation. So, and I think during this session, we will be thinking about our colleague and from Ethiopia and Sudan and all part of the Africa where they have political instability. So we will be dealing for the panel. I will ask to use those who are really present here, because based on, as Dr. Manuel was saying, we need to invest also in technology and innovation. And this is the panel will be leading by Dr. Miriam. Dr. Miriam, thank you.
Right.
Welcome.
Thanks so much, Emmanuel, and thanks so much, Christian and Emmanuel, for that grounding. And really, our thoughts are with Nala and the rest of the people who are going through this, and of course the patients, specifically because this ultimately impacts their ability to access care in these facilities. So I think we have 30 minutes, and I'd like to quickly go through, maybe ask our panelists to quickly introduce themselves. We have a really excellent panel. They're all champions in their respective areas. And so I will quickly ask each of them to say where they're from, where they're working, and then we can move on into the discussion. So I see on the call, Macklin Atieno.
Thank you so much, Miriam. My name is Macklin Atieno. I work with the Kenya Hospitals and Palliative Care Association as the executive director. I'm happy to be part of this session.
Thanks so much, Macklin. Happy to have you. And Liz Guither, I hope I'm pronouncing it correctly. Liz?
I think Liz, she's not yet connected, login.
All right, okay. And then Olaitan Sayanwo.
Dr. Manuel just wrote that Eunice Garanga will not be able to join. So I will suggest to have on a panel Makulin Atieno, Dr. Zipporah Ali.
I think we're going to recruit Zipporah.
Yeah, yes. And also Dr. Emmanuel, okay. Dr. Emmanuel, of course, and also yes. Eva Namisango.
Okay.
Yes, yeah.
So Zippy, you've been co-opted. So if you could kindly quickly introduce yourself.
Okay, this is an ambush.
We agree.
Yeah,
there is no ambush in palliative care.
Yeah, okay, so my name is Zippy, Dr. Zipporah Ali. I'm a palliative care specialist. Formerly worked with the Kenya Hospitals and Palliative Care Association as the ED, but also worked with Nairobi Hospice for over 15 years as a clinician. Currently, I am retired, but I am not tired. I am the chair of the NCD Alliance of Kenya, and still very much will always be an advocate for palliative care as long as I'm alive. Thank you.
And thanks so much, Zippy. Eva Namisango.
Thank you. I'm Eve Namisango, and I'm the Programs and Research Manager at the African Palliative Care Association.
Thanks so much, and for Eve and Zippy for being real troopers, and of course, Macklin and Emmanuel for agreeing to chat. So I think Emmanuel sort of pretty much set the stage for us in the sense that, you know, in the midst of adversity, there's always opportunity. And I think the main bit around this conversation is really to try and reflect about what are the innovations that we're seeing in terms of access to care for access to palliative care services? And maybe we can quickly go around the room and sort of maybe get your sort of first pass quick ideas around innovations that have happened as a result of the pandemic. Madeline?
Thank you very much, Miriam. At KEPCA and in Kenya, one of the innovations that and we've talked about is the use of technology to reach out to patients. So whether it's through telephone, whether it's through use of apps or any other way, it's really worked compared to before, where palliative care was mainly seen as as best presented in a physical environment where you are close to the patients, seeing the patient and talking. But we realized that even using technology, even when someone is far, there are ways in which you can still reach out to the patient. So use of technology has really worked this time.
Thanks, Madeline. And I think that's an important concept in that we've been having to pivot in our approaches to care. Eve, what are your reflections on innovations? And keep in mind that sometimes we think of innovations as, necessarily tools or toys or whatever, but innovations can simply be around systems and service delivery. So just asking you to reflect as well, what you feel maybe are the innovations that you're seeing. Is it similar to what Madeleine's been experiencing?
Yeah, I would say what has been most amazing for me was how us as Africans, we've looked inside and seen how best to use the available resources, the borders. And when people could not move, patients could send motorcycle riders to palliative care service providers, and they would have their medicines given to these people, and they were safely delivered home. So there were no taxis, but you could still get your medication. And for me, that was amazing.
No, I mean, that's brilliant, Eve. I mean, just even having the thought about we're having these riders and now like repurposing them. Sometimes border borders have a bit of a bad rep, but now if we can purpose them for good, then that's definitely something worth sort of building on. Emmanuel, what other innovations have you sort of encountered during this time?
Thank you very much, Eve and Miriam. The thing that I've observed at family level and also in the facility is the whole issue of strengthening self-management. We've had loved ones who are sick and we can't go to them. And then one has to take them through the steps to do the things that they are supposed to do. People who could not use the device to measure their blood sugar to be able to do the same. People who always waited for somebody to come and measure their blood pressure, being able to do it themselves using the blood pressure machine. So strengthening self-management for me has been a big innovation in addition to the technology and the other aspects that my colleagues have mentioned.
Thanks, Emmanuel. And I think that really, really is core to, our mission as healthcare providers, like really trying to develop the autonomy amongst patients and appreciating that we are partners in their health, but they are the primary drivers. And I think autonomy also lends itself more towards shared decision-making, because if you have a sense or you have an idea of what's going on with you, then it's much easier to come at it from a position of strength. Zipporah, any other innovations or reflections that you've sort of seen over this period?
Just agreeing with the rest that a number of innovations have taken place, especially in terms of e-learning. We realize we don't always have to be face-to-face. We could work from wherever we are. I think for us, when I worked at KEPCA, some of the things that we noticed that we were saving on costs, although the offices that still existed because they belonged to us, but we were not buying tea every day, paying for tea, electricity and water cost went down. And this money that can be saved can actually be put into service provision, into reaching out into the patient. So some of the things that also I realized was that, for example, the other day I ordered for my drugs. I live with a number of NCDs. There's an app that's called Livia. You order for your drugs, then what they do is they reach out to a number of pharmacies and get the best prices for you. And when you look at how much you've saved, I saved about $50 on my drugs 2 days ago. If I had gone to the pharmacies directly to buy them, I would have paid that $50 extra for those. So those innovations are very important because these apps actually happened during the last 1.5 years. People brought up things like Mydawa, Livia, where patients can order for the drugs and get them at a lower cost. But I also think that for me, I saw the innovation that I saw happening in this country was the fact that we came together. We stopped working in silos. I'm palliative care, I'm mental health, I'm this. We had the Ministry of Health come up with technical working groups, the NCD COVID technical working group, for example, the psychosocial mental health technical working group. We came together and started thinking, how can we address the challenges that we are seeing during this pandemic? So thinking together, bringing people together. And now I think there's more cohesiveness in our country in terms of health outreach than there was before. And then the other thing was thinking out of the box in terms of funding. Where else do we, approach for funders to help us to, multilateral, multi-sectoral funding? So I think there are many opportunities actually that we can learn from and we can adapt going forward. Thank you.
Thanks so much, Zipporah. And I see, Eve, you have your hand up. Maybe as you make your comments, I would also ask you to perhaps reflect on, we're having all these innovations, which is great, but then we also want to think about how do we ensure that these innovations, as great as they are, do not necessarily worsen disparities. I may not necessarily have a smartphone. I may not necessarily have access to a data plan. So how do we integrate these innovations such that they're not ultimately worsening the gap to access for our patients? Go ahead, Eve.
Yes, thank you. I wanted to make a note that the public-private partnership has never been stronger than it was this time. The private sector capitalized a lot of money. And I think as palliative care providers, we should be leveraging on this initiative going forward. And then we have very strong linkages right now with respiratory health. It is a department that has been, or a specialty that has been silent for so long. And our working relationship is much stronger. And I see their palliative care needs actually being made better and the collaborations strengthened. And I want palliative care to look at all these gains and ensure that as we move forward with all these opportunities and gains. Thank you.
And I think, Eve, what you and Zippy are saying, that there's definitely been more increasing connectedness, more collaboration across sectors. We've stopped operating in silos. I think, Emmanuel, maybe if you want to just comment around how are we minimizing or preventing innovations from worsening disparities?
Thank you very much, Miriam. It's definitely a challenge. That is a challenge to, and that starts right from the investment side. That so if somebody had access to a smartphone, they got the best out of this challenge we had. If somebody had access to mobile money, they had better access to services than somebody who didn't have. So your observation is right that we need to set up a system that does not widen or does not make worse the disparities as we provide the services. Initially, it was the mantra was, oh, you need to be a certain distance from a health facility, and now that has been wiped out by the COVID-19, and it has now zeroed down to access to information and access to other technologies and platforms. It is therefore important for us to interest government into this issue, to know that when they are regulating the use of these technologies and making them unavailable because of costs that they put in, they bear in mind that these technologies are also used for life-saving things like access to health services. I don't think they have heard that enough from us. Here in Uganda, we've also had to engage the Ministry of Finance on the issue of introducing an internet tax where they slapped a 12% tax on access to internet. And we're saying, look, internet is not just for you to make money. It's about people's livelihood. It's about people's health. It's about people's access to services. So we really have a long way to go, and we have to engage by our other colleagues in budget advocacy to ensure that these innovations that are coming up for use in health do not exclude the people who have no access to money, and maybe calling on mobile phone companies and other owners of technology to provide room for the people who may not have all the money they need to access, to use their technology for health reasons. So I see the point, and I think the challenge is big, but we can engage other people outside palliative care in the technology sector and in the advocacy sector to point government to the fact that we need to make these technologies available for all of us.
Thanks so much, Emmanuel. And I think that's critical, as you're saying, just really having multi-sectoral approach. Madeline, any thoughts around how we can integrate these innovations without necessarily heightening disparities?
Yes, thank you. And as Dr. Emmanuel mentioned earlier, one of the important things that was noted was the issue of language, or the way the COVID-19 messages were transmitted or translated, and some people or some different people who are not able to understand the key languages were left out. So I think moving forward, even as we develop IEC materials for palliative care, it's important to consider other ways of communication. So not only in terms of language, but even for people with disability, those who are not able to hear, the deaf, the blind, so that all people, regardless of who they are, no one is left behind in communication about their health. Thank you.
Thanks, Macklin. And you do raise a very important point. And I think, as you and Emmanuel said, words matter. Zippy, how do you think that, or do you know of any attempts that, how are we looking at this in terms of, through the supportive and palliative care lens, how do we sort of integrate these into, I would say, the health system, and how do we ensure that this message ultimately percolates? I think you made some great points about curriculum, but how else can we ensure that the words that we're saying are what we mean to say and that they reach the intended user?
As I think okay, maybe I'll take Kenya as an example. We've done a lot in terms of palliative care for the past 15 years, integrating palliative care into the healthcare system, putting palliative care into the core curriculum for doctors and nurses and the pharmacists. But what I'm aware of is that the nursing department does very well in terms of training. The medical department keeps on talking about crowded, curriculum and everything. So we need to follow to ensure that the training is going on. But I think if you have a policy, which we have just launched a policy recently in our country, that policy should actually be put into action. We should use it to ensure that we're implementing what we put into the policy. We put a number of things on integration, access to medicines, leaving no one behind, reaching each and every person in this country that needs palliative care. How can we work together, bring in all the different players to ensure that this policy is being implemented? And not just that, but also to how do we advocate for our Ministry of Finance, Treasurer, to ensure that they have put a budget towards all these things, because you can't do these things unless you have the money. You can't train healthcare workers, you can't integrate services if you don't have the money, you can't have the opioids and other medicines you need. How do we collectively work together to ensure that what we put on paper is now being put into action? But of course, we need the civil society to be able to do this. We need the voices of the people. Kenya Hospices and Palliative Care Association, NCD Alliance of Kenya, many of these patient-led organizations, community-based organizations, how can we engage together so that we are having the patient also in the forefront of advocacy, demanding that they want their health rights to be, respected. And of course, UHC can actually help solve some of these problems, because if we have palliative care integrated to UHC, which is what we're working on in Kenya, then we can maybe, okay, our UHC isn't working very well right now, but we are hoping that it will work very well through the NHI program. How can we ensure that palliative care is part of the universal health cover, it's part of the health systems? So again, there are many things we can really think around, and I think it just goes beyond the palliative care providers. It has to bring in many other people. The Miriam oncologists have to also fight for palliative care to be fully part of the comprehensive care for cancer patients. So everybody has a role to play, and if we come together, including the patient, I think we can succeed in a lot of things. We've ignored patients for many years. It's time now we actually make sure patients are in the forefront.
Thanks, Zippy, and really powerful words around really having the need to have an integrated approach and really investing, because I think sometimes we think of it as health expenditure, but rather looking at it as health investment. I see Macklin has raised her hand, and then I think Anne also has a comment. Macklin and then Anne.
Thank you. Just to add on what Dr. Zip is talking about, comprehensive engagement. In Kenya currently, there's an opportunity for engaging the community health volunteers. And that's a good opportunity for reaching out the people in the community, but as well as demystifying and clarifying the palliative care message, because the community health volunteers, they work in the villages where they come from, and there are a link between the healthcare system and the popular sector or the ethnic beliefs. So that's a very big opportunity to reduce the disparity, as well as deliver clear messaging and provide appropriate palliative care to the patients, the community. So moving forward, one of the things which the government, like in Kenya, need to consider is looking for ways of compensating the community health volunteers so that they're motivated to be able to support the care pathway from the healthcare facilities to home care. Thank you.
Thanks so much, Macklin. And as you said, really important point around getting our community, just getting that grassroots community engagement and figuring out ways that we can actually sort of strengthen that from the ground up, whether it's through models that actually compensate so that we're staying motivated. Anna, you had a comment as well.
Yes, thank you very much, Miriam. It's something that might be a little bit different. That sudden realization of things that matter. This has been brought in by this COVID pandemic. I mean, people have decided to shake off excess baggage and actually revisited the basic lifestyles, like even the old games that we used to play with our children, the traditional games during the lockdown. People explored those things, and I think these are positive things that happened. That family connectedness in terms of just the nuclear family, besides the fact that, there could have been some challenges as well, but those that went into this deeply, it sort of like brought people together. And there's also that heightened awareness in the importance of palliative care. So while some people may not have really understood or not even cared to know what palliative care is, I mean, with this COVID pandemic, people then began to realize that, oh, there's this palliative care that can be helpful to people. And this has been an advantage brought about by the COVID pandemic.
Thanks so much, Anne. And I think you've really honed into a key aspect of just our connectedness, celebrating sometimes our Africanness, which we were quick to sort of throw away, but sort of really circling back to what Christian likes to call the Ubuntu principle, and just, the connectedness and support for each other, and really, which are the tenets of palliative care. I see, Christian, you have your hand up. Perhaps you could maybe just weigh in as well.
Yeah, yes, Miriam, thank you. Just before Emmanuel, because I know that Emmanuel have a meeting in a few minutes, to Emmanuel and ZP, you mentioned something really important about investment in human resources. But my question is, how are you going to retain the resources trained or the human people trained in Africa, because one of the problem we have is the brain drain. And for all disciplinary we have in medicine in Africa, but especially for palliative care, which is considered the fifth wheel of the carriage in public health. How now, if you have the money, you train those people, and if you want to retain them, people will mention about incentives. You need to increase money, we need to increase budget, so which will be conflicting with the other budget. So for you and for your opinion and the ZP, how do you make sure that people train will stay and deliver in Africa? Thank you.
Let me go first, then Zippy will go after me. She has been at it longer than me. I think.
You go first. That's a tough question.
The issue is that we've been pushing for governments to ensure that the palliative care people who have been trained are retained within the systems, and that they are recognized as such. If you have a nurse who is a palliative care specialist, recognize her as such. If you have a doctor who is a palliative care specialist, recognize them as such. In addition to the other cross-cutting things, making their workplace comfortable for them, making them able to deal with the burnout, and having access to the basics. I think that is very important. And we've seen that happen in a few countries. I know that Malawi and Zambia are trying to push something. Uganda is also trying to push something. Countries like Morocco and Seychelles are ahead of many of us. So I think we can do our best, first by looking at the systematic things that we have to do, the recognition, placing them at the right space where they should be, and then providing the things that they need to use to enjoy their work. But it's going to be tough. Christian, it's going to be tough because many countries are now poaching on African health workers. I've even heard of a country in Europe which has removed the old requirements they had for pre-training for Africans to go to their country. They are now saying you can come as you are. So it's going to be tough, but we have to alert our governments to it. Thank you very much.
Okay, Emmanuel has said it all. I think recognition of palliative care practitioners, especially the nurses, is very important. And also not just recognition on paper, but also even in terms of, how you have a career pathway. When you have done a certain course, then you are recognized at a certain level and your salary also goes up. So those are some the things that are pushing people out of our country is really the compensation. They want to give services to their own, but they're not well compensated. If you go to the West, a palliative care nurse is really valued because the work they do is very difficult. They are paid well, they're taken care of. So we need to review how we, compensate our nurses, how we treat them, even the doctors and the rest. But again, talking about the brain drain, Dr. Manuel, just off the record, 10% of our nurses failed the exams to go to the UK. And we have been told that it wasn't because they failed. It's because the government is insisting that 30% of what they're going to be paid should come back into the Ministry of Health. Now, of course, this is not fair because this person is the one who's going to work wherever they're going to work. Why do you want them to bring 30% back into the country? So again, of course, this demoralizes people. They don't want to travel. So I think there are many things there are many barriers, Dr. Mutebi, that we put for our people, which we don't need to put. We treat our people as if they are our enemies. We are fighting with them. We need to be more encouraging. And I think Kenya is slowly waking up because recently we got circulars to contribute to SOPs for doctors, SOPs for dentists, SOPs for nurses. And then they actually asked us to include palliative care as well, something that has never been done in this country. So this also might actually help the recognition of palliative care practitioners. And I know the Nursing Council of Kenya right now is working on having even nurses. Nurses are not allowed to prescribe, although they're the ones who give the medicines in the hospices, but they're not legally allowed to prescribe. And now the Nursing Council has woken up after 10 years of trying to talk to them to actually look at how can we have nurses prescribe opioids? How can we recognize them? What do we need to do to build their capacity? These are some of the things that make, motivate people to work and to remain in your country, that you can give them some of these task shifting things. So there are many things, and like Emmanuel has said, I think we just need to strengthen our systems and look at how can we make people feel valued, because I think it's not always about money. It's also how are you valued in the system. And again, even practitioners, doctors need to understand that palliative care teams are supposed to be there from the beginning of a diagnosis, so that you're not making them those people in that corner that we send patients to when they're dying. Then they start feeling, why are we isolated? Why are you the ones who are dealing with only the dying? They need to be put into the system where they actually are part of a patient care from the beginning to the end. Thank you.
Thanks, Zippy and Emmanuel. I think those are really powerful words. We're on the hour, so I think we just have to give a closing. But I think you all, the panelists, Eve, Macklin, Emmanuel, Zippy, you've really honed in on the key aspects that really need to come through, and that's the investment in the workforce. And again, really putting our money where our mouths are, and really investing in palliative care. And I think in closing, we would leave with Macklin's remarks that this is a really good time to redefine the role of palliative care, not just in cancer, but in all aspects. And this should be something that should be transcendent through our entire health system. So thank you once again to all our panelists, and looking forward to continuing this discussion. Thank you, everyone.
Thank you, Miriam.
Back to you, Christian.
Yeah, thank you, Miriam, for the great moderation. And I hope you'll stay with us for the, now we're going to our last session, talking about including palliative care as part of universal health coverage. What have government done? So we are lucky today to have different panelists, experts in Africa working in palliative care, which we hope from your expertise, from your guidance and comment and input, we will be able to have a sense of what we can be to continue to support our government and what we can do in our part. So I would like to ask the speakers to introduce themselves. I would like first to start by Rene Krause. Rene?
Hi.
Yes, we can hear you now. Can you introduce yourself, please? Thank you.
Okay, thank you, Christian. I'm Esther Dinabel from Cameroon. I'm a medical oncologist and palliative care doctor also, and also president founder of civil society association called Volunteer for Palliative Care, who is advocate for palliative care in Cameroon. Thank you.
Thank you, Dr. Esther. So we are really happy to welcome you on this session. Rene Krause, is Rene not yet? Eva Namisango, I think you can reintroduce yourself again.
Thank you, Eve Namisango, and I'm also a palliative care specialist and currently programs and research manager at the African Palliative Care Association.
Thank you, Eve. Now I'm going to ask Anselm Kananga to introduce himself.
Hello, everybody. I'm Anselm Kananga from DLC. I'm a palliative care specialist nurse. I'm a founder of Palliative Care Association Pallia Family. It's a network of volunteers from nurses, psychologues, doctors, physicians. They are promoting palliative care in Kinshasa. And I'm happy to see and to hear in the session. Thank you, Christian.
Yeah, thank you, Anselm. I think we will have a great session. And Zippy, of course, we're going to trap you again because as Rene Krause is not there, so I'm really, as you know, always happy to have you in the panel discussion. I would like to start first. One of the article was written by Zippy, Dr. Zippy, when you mentioned that palliative care has to be funded by the government, not by civil society organization. So just a tricky question and very provocative. Do you mean you don't need a civil society organization?
No. Is it the article that was published recently?
Yes, yes.
It wasn't talking about not needing civil society. It was just really talking about the issue that that we have to, our governments need to take responsibility of palliative care. Our governments take responsibility of many other things in terms of healthcare. Why not palliative care also as a government responsibility? The government needs to invest in palliative care and support, just like a woman who's pregnant goes to an antenatal clinic and is taken care of in a hospital, government hospital. A palliative care patient should be able to go to the hospital and be taken care of their needs. Civil society is very important in terms of advocacy, accountability, and the rest. And of course, even funding is also important if we can get funding. But as we are seeing, funds are going down, like I said, they're diminishing everywhere. So we need to encourage our governments to put palliative care in the forefront to, and recently APCA helped us do a costing for palliative care for Kenya, which we hope that it can be replicated in other countries, the same costing, the system we used can be given to other countries to look at how they can cost palliative care. The amounts that came out of that costing were huge, enormous, and there's nobody who's going to be able to meet these amounts by themselves. So collectively, we need to work collectively, whether civil society or whether development partners, donors, funders, but mostly the government needs to take responsibility, especially if you're talking about UHC. UHC is supposed to be government-funded projects mostly. ODA used to fund a lot, but it's going down now. So our governments need to prioritize palliative care is what I meant.
I know. It was just very provocative on that. But thank you for this great article. I would like to ask Dr. Esther Dinabel. I know you're working from Cameroon, and you are among the few palliative care physicians I know who really dedicate your time and your resources to improve the palliative care program there. So, how is universal health coverage in Cameroon?
No.
We can't hear you very well. Can you just adjust?
Hello, Christian?
Yes, now we can hear you. Yes.
Okay. Now it's okay?
Yes, it's okay. Okay, go ahead.
Okay, yeah. Concerning the situation of palliative care in Cameroon and the offer of palliative care in health facility, it is not palliative care. It is not yet integrated in the minimum package of care that a health facility can offer in Cameroon. So it is just personal initiative of civil society organization or personal initiative of some physicians that have been trained in palliative care and who have the main who want to offer palliative care for the suffering population in the health area where they are working. So it is still difficult in Cameroon despite all the advocacy that we are doing. And in the region where I live in Cameroon, in littoral region, since 2018, we are in the process, we are implementing a project called ESOP FOSA, who have the goal to implement and integrate palliative care in public health facilities. And since we started this project, the first year in 2018, we got the subvention of APCA for the training of 71 health professionals in palliative care. And after that, we got 8 health facilities who started a program of palliative care. But because the government need to move health professionals in all the health facilities in the country, there were some of the professionals that have been trained now. So, so in some health facility where the program palliative is stopped. So it is the reason why I agree with the doctor who speak before me. That's really important that the government should take the responsibility and integration of palliative care in the healthcare that it can give. Thank you.
Thank you, Esther. Thank you for mentioning that. And as Dr. Zippy was mentioning, it's really important that the government should invest in palliative care. Anselm, what is the situation of palliative care in DRC Congo, and how is University Health coverage?
Yes, thank you, Christian. Do you know I'm a French people? This I tried today. I'm French people. I'm trying today to speak English, but I want to speak slowly, because
yes.
my English is not perfect. But I want to say in DRC is that is an it is a big country. It's a big country, it's a big problem also in DRC, But I think in the palliative care, that is an integration process, because we have many challenge, but I think now they start to integrate the approach in the Ministry of Health. And it's now we have the last 10 years, we make many sensitization, we make training, we make congress, and now the Ministry of Health, they see now the importance of palliative care. It's very appreciated. But now to integrate the palliative care packet as social security is now a new challenge, because we must now to integrate the palliative care in the financial system of the government. That is the challenge now. That is, I see now that's the second challenge, because the first challenge was to integrate the approach. Now the approach is integrated for the training for the nurse, the training for the doctors. We start now with the module, but to integrate palliative care, the packet for the financial of the government is not a challenge. But I see now is the will, the political will. They have a political will, and they try now. I was yesterday with the Minister of Health, and I speak with him. He said to me, we want to make a conference in December, and we want to take palliative care and universal coverage health, and to see how we can to manage the packet of palliative care to the financial system. I think we are in a challenge, but what can I say? Je crois.
I believe.
I believe, yes. I believe that it will come. It will come, because now they understand and they see the effect from palliative care in our unit at the university hospitals. And we have now 4 units of palliative care. And now they see the work, and they try to understand how to manage palliative care in the approach. That is the reality in DXA. Just in the mental, they are acceptable now, but now they're looking at finance. And I think also, when ZP say is very important, the country like DRC, it's important to have also the partnership between private and public. Is very important, because they have many priority, but we as civil society, we are focused to promote palliative care. We have another association, and we pick them. Nous les gardons conscients. What can I say in English?
We keep them focused. Yes.
Focused. That is our challenge. I know I was with Emmanuel in April in Kinshasa, and I see how is the engagement of the Ministry of Health. And now I think we have many promises, but we follow up the engagement. That is the reality now on the floor.
Thank you. Thank you, Anselm, for the great effort to speak in English. As you may know, in palliative care, we have no language. It's all about compassion.
Yes,
yeah,
yes.
So
Thank you, Christian.
Yeah. So Eva, I know you have a lot of experiences in research. What do you, in just few words, do you see university have a coverage for palliative care, especially in Africa? What's the image? What is the global view we have now in Africa? How far is it moving so fast? We are still stacking, or we are still behind compared to other continents? Thank you.
Thank you, Christian. We are still behind, but we are moving. And I want to credit African governments. So far, they are trying to address the issue of equity by promoting the integration of palliative care within existing healthcare services. And I think that's a huge step forward. And they are also undertaking, baby steps. They are looking into insurance, and they are trying to meticulously appraise, is this something that governments can take on? Is it affordable? And I think if we can get palliative care into national health insurance schemes, we'll be able still to address the issue of equity and also quality. The same quality will be available for all patients, irrespective of socioeconomic status or type of diagnosis. Thank you.
So what is the percentage in Africa? Is it based on the universal health coverage? Is it 50%, 40%?
No.
Just no?
I would say about 8 to 9%.
Wow.
We still have a lot of work to do, but the baby steps are going on.
Yeah, thank you, Eva. Zippy, you mentioned about investments in the financial, and I know all ministers of health, when you mention about money, they run away. And this is, it's everywhere. It's everywhere. When you mention, yes, when you mention about you need financing, they run away. So what I know it was a very beautiful piece of an article you wrote. And I would like just if you can share one or two strategies you think Minister of Health could adopt before I can go to Dr. Esther Zinabel and Anselm. Thank you, Zippy.
That's a tough one. Miriam Mutebi, you're from Kenya. What do you think our Minister of Health should adopt?
Yeah, Miriam, you're also welcome. Yeah, because you are the Vice President of
yeah, she is the Vice President of IOT. She's in the IOT, she's our chairperson of KESHO. Miriam, please help me. Yeah, I've been working with this government for 15 years advocating, and now they're listening.
But let's start first by Zippy, because you wrote a very beautiful article, and then we'll move to Miriam and the rest of the panelists. Just in a few words.
Okay, so I think like I said, and I keep on repeating the same things because that's really the only way it works. We have to make our systems understand the benefits of palliative care. And I think for us in Kenya, we started with doing advocacy at the same time integrating services. We did not have a policy. Policy has just come a month ago. Mm-hmm. But because we were able to showcase that palliative care is cost beneficial, from the reports that we sent to the ministries, they realized patients whose symptoms are well managed stay at home and don't occupy hospital beds, which is a cost to the government, to the hospital, to the patient. So really focusing on our government, our healthcare systems, our care providers, and even our patients and families understanding the benefits, the cost benefits of palliative care is very important, but also the benefits to the patient in terms of outcomes, patient's outcomes. The symptom management, the psychosocial support, that all holistic approach is also something that we can use for advocacy. So I think we need to show that palliative care works. One, we need to show that palliative care is everyone's business. We need to show that palliative care is part of the health right. In our country, we talk about access to promotive, preventive, curative, rehabilitative, reproductive. It used to stop at reproductive. But in 2013, we added palliative care as a human right in this country. It's in our Patients' Rights Charter, it's in our health law. And now, as with these documents are being reviewed, they're going to be adding mental health, because again, mental health has come out very clear. People in the mental health space have really done a lot of advocacy. So I think showcasing what benefits palliative care has in terms of even reducing costs and patient outcomes and family benefits and healthcare workers' benefits is very important. So again, if you want something to be accepted, you have to show that it has value. We have to show the value of what palliative care is.
Exactly. And Miriam, just a quick one.
Sure, I think just to underscore what Zipporah is saying about showing the value, but really having the argument around sort of what we had referenced earlier as health investments rather than expenditure, and sort of showing that, so again, reframing the narrative around palliative and supportive care services actually coming upfront in the preventative, because if you're actually having them say at the word go, then overall because again, I think Eva's also just made a comment about it needs to be economically sound, then showing the value that these would definitely have downstream in terms of reducing costs to the system. So it's ultimately a saving if we start to invest in these early. I think from a, sorry, I'm having a bit of an echo. I hope you're hearing me okay. But again, in terms of looking at what can bodies like Aortic and other civil societies do, I mean, I think we have an undertapped potential, especially in terms of trying to mobilize regional organizations like the African Union. And so if we're able to figure out ways that where we hold our governments accountable and say, listen, and not just necessarily going as little pockets, saying this is an overall, we do need to invest more in health, and palliative care services and along all other services are part of the spectrum that do need to be considered in terms of what the health expenditure is, because we're still consistently having countries in sub-Saharan Africa having less than 4% of their GDP in health investment. So I think there's really a push for education and civil society. And so there's an opportunity that we could leverage as the different organizations, whether Aortic, whether KEPCA, whether NCD Alliance, is to come together and really try and push that agenda forward. Thanks.
Yeah. Thank you, Miriam. And Eva mentioned, just wrote on the chat, as an economist, I would say government can only provide what they can afford. This is totally right. So the package of care we propose must be modeled to fit within the national health sector's budget. Then government will listen. And Maculin also mentioned, we can tailor our solution in line with the government's interest. Dr. Dinabel, you are the Vice President of Francophone Federation of Palliative Care. And I think you mentioned, the only palliative care association or organization working in Cameroon. So as we said, when you mention about financial, government is still, there's still fear when people mention about financial issues. So what do you see your perspective as one as a vice president in the Francophone countries, but also from Cameroon, to see universal health coverage to be really integrated? Dr. Dinabel? Yes. Okay, I think she's, yes. Hello? Are you there? Yes, no, we can hear you. Yeah, we can hear you.
Yes. Oh, okay, sorry, I was mute. I thought I was on mute.
Okay, no problem.
Thank you, Chris. Thank you, Christian. Francophone Federation for Palliative Care, we are advocates for and we are supporting palliative care organization in the advocacy near the government to end palliative care. Also, our main point is also to have a palliative care in the organization, administrative organization of the Ministry of Health, because this is very important. If we have a palliative care coordinator or a palliative care responsible in the administrative organization of the Ministry of Health, the ministry will allow this person to make a development plan, a plan of development of palliative care in the whole country to meet the needs, and also showing the government the really need of palliative care by conducting inside the country a survey on palliative care. What is the current situation of palliative care need in your country? Sometimes government need to have facts to understand well that the situation is very critical, that people are suffering and pain control is not well done in their country. But also they need to understand that supporting palliative care is not really costly for them, because sometimes they are the things palliative care is really costly and will not bring back money to the minister or to the health facility, like for example gynecology or radiology.
Yeah, thank you, Yeah, thank you, Dr. Esther. So we are running out of time. Just 20 seconds to Anselm before to give the mic to Anna Nyakabau to just make a wrap up. Anselm, just in one word, palliative care in DRC Congo, what is your hope?
Yes, in one word, that is the. I think it's not easy in one word, but I want to try. I think it needs leadership. Okay. Leadership is very important. Leadership for the ministry. Leadership.
Thank you, Anselm. Anna, can you just wrap up? And I would like to thank all the panelists and the speakers for your comment and input. And as we said, we have still a long way, but we are very happy for the step have been made. Anna?
Thank you very much. Indeed, palliative care needs leadership. It actually increased the awareness of death and amplified the need for self-management in the midst of infectious disease, thereby amplifying the need of autonomy. It helped people to come together and start thinking outside the box, increasing connectedness, and made people move away from silos. The need for comprehensive engagement, particularly involving the community volunteers, was also highlighted. Integration of palliative care into public health system is also an important aspect that has been talked about, and also investing in the human resource capacitation is key, using platforms, including the e-learning platforms that have been actually opportunities that have expanded since the COVID-19 pandemic. Innovations in telemedicine investment and systems that deliver patient consumables have also been highlighted, and there is need for mechanisms of dealing with isolation. Communication, which is key in palliative care, has also been talked about, particularly also taking into consideration the different languages of our populations. We need to leverage on COVID-19 resources, as resources have been an important aspect of health system, and be innovative in terms of investing into finding ways of fundraising. There is also need to invest in new platforms to palliative care education, and integration of palliative care into infectious disease management has been highlighted. It's no longer the time where we would just be working as palliative care practitioners without realizing that both the patients and the healthcare workers are at risk of infections. And underlying all this is investment into strong, resilient healthcare systems. And the need for policy, putting policy into action was highlighted. So COVID-19, besides bringing out all these challenges, have made us wake up, and I think we look forward to a bright future as far as palliative care is concerned. Thank you very much.
Thank you, Anna. Thank you for this beautiful conclusion. So I would like to thank everyone, starting by my colleague moderator, Dr. Miriam. And thank you, Zippy. I know you came as someone just an observation, an observer, but
I came in illegally.
But thank you for being here. Thank you for Anselm from DRC. Your English is very perfect, don't worry. And also for my colleague from Cameroon, Dr. Dinabel, Executive Director of KEPCA, Makrillin, our expert health economist, Dr. Evie, and also the rest of the panelists and also the participants. So we will meet again tomorrow at 6 p.m. We will talk about access to essential medicine in palliative care and the rest of the topic on access to patient voice as well. So I wish you a very good weekend, and may God bless you. Thank you so much. Bye-bye.
For a good job.
Thank you so much to our two facilitators, Christian and Emmanuel, and a special thanks to Zippy as well, who at the last minute involved herself, and she's just showed her passion towards palliative care. And thanks for the lessons that have been learned. What we want to also remind people is that these will be recorded after 48 hours, all these sessions, and they will be available for the next 6 months for all those people who want to have a relook, or also for those who missed out. Thank you so much. Thank you.
Okay, so while we prepare to go for the break, please remember to network. Remember to go for the treasure hunt, and the photo booth is also available. Enjoy the break, and we'll see you back at 12 noon. Yeah, thank you so much, and have a good break.